I hope I'm audible. Yeah. So today's topic is issues in grown-up congenital heart diseases. As we all know that with advancement in the cardiac surgeries, we just a minute. Let me just play my PowerPoint. Advancement in technology and improvement in the outcomes of congenital heart surgeries, we are no more only seeing the pediatric patients, but we are also seeing the patients who has undergone the palliative surgeries or definitive surgeries in their childhood. And with advancement in the free availability of echocardiography, we are seeing patients who are unoperated congenital heart diseases like ASD, PDA, and ventricular septal defects as well, and rarely univentricular hearts as well. So this is a study which was published in Circulation 2001 by Nimin et al. As we can see here, that most of the post-tricuspid shunts and pre-tricuspid shunts have good survival rate if they are without significant pulmonary artery hypertension up to 35-40 years of life. But with univentricular heart, they have decremental outcome after 20 years survival. And similarly, since earlier it was the atrial switch was performed for TGA patients, so that also has been contributed for decremental survival for some of the patients after 25 years of age. But overall, the response of congenital heart surgery is wonderful, and we are seeing patients in their 40s and 50s as well. So more we are going to advance in age, more and more we are going to see the patients who has grown up and has reached the adulthood, into their adulthood, and who has been undergone congenital heart surgery, palliative or definitive. So we are going to go through the presentation by case wise. So what are the challenges in grown-up congenital heart diseases? This term has been coined by Jane Somerville, who is the pioneer in grown-up congenital heart diseases. She has done a lot of workup in their with respect to the various problems and challenges that we see in grown-up congenital heart diseases. So what are the problems that we encounter with them is ventricular dysfunction, arrhythmia, coagulation disturbances. Suppose they are they have not undergone the complete correction, any palliative surgery has been performed, or unoperated congenital cyanotic heart diseases or Eisenmenger syndrome, we will face coagulation disturbances. We are going to see pregnancy in operated or unoperated congenital heart diseases, pulmonary hypertension related problems, and of course occupation, like what occupation is safe for them and what are the occupations that they may not be able to perform due to constraints from the heart. So these are the challenges when we see a patient who is grown up and who had a heart disease palliated, surgically treated, or has not undergone any of the treatment modality. So this is our first case. He is a 36-year-old gentleman, has undergone Fontan surgery, classic, semi-classic form, in which the RA was connected to the pulmonary artery and the antegrade flow was completely abandoned. Had Fontan surgery at the age of 23 years, that is 15 years back from now, and has came with recent onset of dyspnea on exertion, just 3 to 5 days, and recent onset of desaturation. When he came, he was dyspneic and he had saturation, room air saturation was 75%. So this is an ECG of this particular gentleman. So what we can see, as I told you, that is a cyanotic heart disease, but we are seeing here left superior axis, more of the left ventricular forces. So obviously the differentials are like tricuspid atresia or DILV. So this patient had a tricuspid atresia and atrial flutter, as we can see in this patient, with almost ventricular rate less than 100, so slow ventricular rate. So this patient had atrial flutter with stable ventricular rate. So we have done some of the investigation because he had one episode of hemoptysis also. So we have done the coagulation profile, which was normal, platelets were normal, WBC count was normal, he was polycythemic, but D-dimer was positive. So D-dimer is an indirect evidence of pulmonary thromboembolism. So this is his axial cut of CT scan from suspicion of thrombotic episodes, because echo was also showing that there is a thrombus formation in right atrium. So that we suspected that this patient might have had pulmonary thromboembolism as well, diffuse in presence of atrial flutter. And since D-dimer was also positive, so CT scan was done, which is showing that there is a left pulmonary artery clot. And then we can also see that the contrast has been given from left hand, and this is the innominate vein, but there is lot of the contrast filling defects are seen in the SVC and innominate vein, as we can see here that this is the innominate vein SVC junction where there are the filling defects, and this is a venous run predominantly. Then the blood is entering into the right atrium, and the clots are seen around the entry point of SVC to the pulmonary artery, and we can also see the backflow of contrast into the hepatic veins and into the IVC. So this patient had sluggish circulation into the right atrium. He had and there are filling defects seen into the innominate vein and SVC. So he had obviously thromboembolic substrate, and thromboembolism has happened to the pulmonary arteries. So he was managed with beta blocker, heparin, and since after heparin therapy also there was no improvement in saturation, so thrombolytic therapy was given, and later on with stabilization he was added on to low dose of amiodarone, because we don't want to convert him, because more of this thrombus will enter into the pulmonary artery, and later on he was put into the anticoagulants with maintaining INR 2 to 3, and RF therapy for atrial flutter was planned. So as we can see that this is an adult patient who has undergone a Fontan surgery, and he is obviously facing the problems of Fontan surgery like arrhythmias. Atrial arrhythmias are very common, especially classic arrhythmias or lateral tunnel Fontan, as we all know. So this patient, the right atrium was connected to the pulmonary artery, so he was more prone for developing atrial arrhythmias. Then some of the other problems are protein losing enteropathy, cyanosis, or hepatic dysfunction and thromboembolism due to atrial arrhythmias, or sluggish circulation can itself lead to the formation of thromboembolic episode. So this patient had thromboembolism and atrial arrhythmias. Gradually this patient has improvement into the saturation, but obviously he is not completely asymptomatic patient. And he will be facing the problems of the Fontan again in the future. So we'll just see what are the problems that a typical Fontan patient sees. Atrial arrhythmias, which are very common, up to 50% of them will be having atrial arrhythmias. They are mostly atrial in origin rather than ventricular. Then macro re-entry arrhythmias are common. And in all these patients, radiofrequency ablation is possible, but wherever right atrium is enlarged in shape, automatically radiofrequency is again a challenging thing, and that's why there are high incidences of recurrence rate after RF ablation as well. So we have to put them on anticoagulation profile, and we have to give long-term antiarrhythmic drugs in all these patients, and may not achieve the sinus rhythm. And protein losing enteropathy is a very challenging complication in Fontan patient. They have got loss of proteins from GI tract due to elevated systemic venous pressure is a proposed theory, but as we all know that they are 5-year survival is only 50%, and very limited treatment options are there. People have tried medical therapy, octreotide, inotropes, diuresis, protein supplementation, but nothing appears very promising in protein losing enteropathy patients. They may have cyanosis and thromboembolism as well. So cyanosis might be due to fenestration, like we always put in them to maintain the cardiac output, or pulmonary AV malformation, backfill leak, systemic collateral or systemic to venous collateral. All these are the causes of desaturation. In our patient, saturations were low because of obviously one of the pulmonary artery was blocked, left pulmonary artery was completely blocked. There was development of systemic to venous collaterals, and that's why the pulmonary venous phase was filling simultaneously as soon as the injection was given into the SVC. So all these things was making him sinus, and obviously there was VQ mismatch to the left lung because there was no perfusion to the left lung, whereas ventilation was still happening. And thromboembolism is quite possible because of persistent low flow rate. We all know it's a low pressure circuit without any atrial systolic or ventricular systolic kick present in the Fontan circulation. Presence of atrial arrhythmias, poor kinetic energy and dilated chambers make them prone for thromboembolic episodes. So we'll see our next case that was about the Fontan, what challenges they see when they grow up into the adult age group. This is the second case who is a 25 years old housewife, came incidentally diagnosed as hypertension and she was planning pregnancy. So the echo showed that there is a coarctation of aorta and then the CAT was performed. This is a pigtail catheter from the right radial artery. It's a marked pigtail catheter and we can see that there is a discrete coarctation from coarctation of aorta is seen, which is next to the left subclavian artery, and collaterals are also seen. So since she is planning pregnancy, there is a hypertension. These are all the indication to treat coarctation prior to the pregnancy because they have got very high chances of fetal loss and maternal adverse events as well if this goes unnoticed and they go into the pregnancy. So we have taken this patient for the stenting. So this is a non-covered CP stent. So we are just checking the position of the stent. This is little bit into the subclavian artery. So the stent should be pulled towards descending aorta. Here it was pulled towards the descending aorta and the inner stent was inflated. And then we'll check the position of the stent again. So this position of the stent appears good and then the outer balloon will be inflated. As we can see here that the outer balloon is getting inflated. And then this is the final stent position. So this patient had disappearance of vest and upper limb, lower limb pressure difference was minimized to less than 10 millimeters of mercury. That means there was no significant gradient from upper limb to the lower limb, and good flow across the stent was noticed. But is it the final therapeutic option for the patient? So from intervention point of view, we have reduced the gradient, but they are going to face certain problems into the future. It has been found out that they have got 25% higher chances of sudden cardiac death than the normal population because of various causes, because of hypertension, Berry's aneurysm in the brain, or aortic aneurysm can rupture. So they have got higher chances of sudden cardiac death. So all these things, risk needs to be explained to the family. There are treatable things that we have done, like we have given repaired the coarctation and we have reduced the gradient, but they may persistently had systemic hypertension due to hypersympathetic activity. 70% of them may remain hypertensive throughout their life, and especially those patients who has got delayed coarctation of aorta repair, like in our patient. All these patients have intrinsic aortic abnormality, that is stiff aorta. That's why they are more prone for systemic hypertension or essential hypertension in absence of any gradient across the coarctation of across the stent. And they may have increased sympathetic activity also. They may develop recoarctation, 8 to 50% may develop recoarctation. They may have aortic aneurysm, especially if it has been repaired by Dacron patch. And as I said, they may have incidences of sudden cardiac death as well. So all this risk needs to be explained to the family, and all these things they are going to carry during their pregnancy as well. So they have got higher chances of developing hypertension throughout their pregnancy and hypertension related problems. So close watch is required in all these patients, and they may require antihypertensive therapy, maybe lifelong as well. So this is the next patient who has been given by my colleague Dr. Sailila. So we'll see our next adult. She is a 19-year-old young girl who is a follow-up case of tetralogy repair, and she had pre-pulmonary artery regurgitation. That is severe pulmonary artery regurgitation, and she has come with a progressive dyspnea on exertion. As we all know that tetralogy of repair, some of them require pulmonary transannular patch across pulmonary valve, and because of that they go on to develop pulmonary regurgitation. Pulmonary regurgitation can be well tolerated till initial few years of life and in post-operative state, but later on they may have dyspnea on exertion due to progressive right ventricular dysfunction, tricuspid regurgitation, or they may develop ventricular tachycardia due to progressive right ventricular dilatation. So all these things makes them symptomatic, and they may require treatment for pulmonary regurgitation. So we have done to quantify right ventricular function and right ventricular volume, the MRI was performed, and she had severe pulmonary artery regurgitation, that is 52% fraction. More than 25% is only very significant. She had almost double of that, that is 52%. Right ventricular end diastolic volume was 159 ml per meter square, very high. Systolic volume was 86, and EF was 46%. That means there was mild right ventricular dysfunction, but left ventricular function was normal. And these are the CT pictures which show that the RVOT is quite dilated with good branch PA anatomy. The right ventricular at the site of RVOT diameter was almost 40 mm, and narrowest part was 31 mm of size. These are the dimensions which are required for the replacement of the pulmonary valve, so they were taken. So what to do with all these patients? They are symptomatic with pulmonary artery regurgitation, pre-PR, and right ventricular dilatation. So as I was talking about that, it was initially well tolerated, but gradually due to progressive right ventricular dilatation, they had due to progressive right ventricular dilatation, they have right ventricular failure and dyspnea on exertion, and they may go on to develop atrial and ventricular arrhythmias. So JIVA recommendation has been given for pulmonary valve replacement. So it has been recommended that pulmonary artery regurgitation fraction, if it is more than 25%, and any of these two criteria is getting fulfilled, then they are the candidates for pulmonary valve replacement therapy, either surgically or transcatheter modality. So these are the recommendations are right ventricular end diastolic volume index more than 150 ml, or systolic volume more than 80 ml per meter square, ejection fraction right ventricular ejection fraction less than 47%, and right ventricular ejection fraction less than 55%, right ventricular artery aneurysm, QRS duration more than 140 milliseconds, they are prone for developing ventricular tachycardia, sustained ventricular arrhythmias, tachyarrhythmias, if there is RVOT obstruction, or there is severe AR or aortic root dilatation is present. So these are the indications for pulmonary valve replacement. So our patient was, as we can see, that the volume was measuring more than the normal and into the criteria for pulmonary valve replacement. So we'll just see that the angiogram of this patient. This is a pictorial catheter, lateral view into the main pulmonary artery, and we can see that there is a free pulmonary artery regurgitation, severe pulmonary artery regurgitation is there, and RVOT is dilated. So this patient was taken with intention to put transcutaneous pulmonary valve replacement, and that's why this is a sheath and a valve is there inside, stent built. The valve inbuilt into a stent, which is 36 venous valve, and desheathing is performing here. First, we are checking the position whether it is across a pulmonary valve or not. So it is well across the pulmonary valve, and then desheathing process is taken place, and valve was implanted across the RVOT at the level of pulmonary valve. And then the final angio was done. This is the angio into the pulmonary artery, pigtail angio into the pulmonary artery, and we can see that there is no pulmonary valve regurgitation here seen. So with very good results. And then the post-operative echo was performed. We can see that very competent pulmonary valve is seen, and stent is there in the C2, and color is showing there is no significant pulmonary artery regurgitation with good antegrade flow across the RVOT. So should we post all patients for pulmonary artery replacement, all tetralogy repair with pre-PR? Should they undergo pulmonary valve replacement therapy? So the results, what the results are saying, first we'll just check with that. So Therin et al., they have found out that the monomorphic PT with the incidence has been reduced from 22 to 9%, but with DT cryoablation also they have performed in all these cases. And QRS duration, it did not become normal, but it did not increase as well. Ventricular function did not improve. It remained stabilized, but it did not deteriorate as well. And left ventricular function also remained same, but there is a significant improvement into the right ventricular function. So it is really a debatable topic that what patient should undergo pulmonary valve replacement and at what level. If we wait for right ventricular dysfunction to set in and then to replace valve, we know that the right ventricular function may not become normal after that. And if we post all patients for pulmonary valve replacement, then that is also not ideal because it is very costly affair. Transcutaneous therapy is very costly, and it has been involved, some morbidity is associated with that, and mortality is quite less, it is less than 1%. And wherever it is not available, we cannot perform surgical pulmonary valve replacement because again it is a high risk procedure. Redo procedure with risk is involved. These stents, the outcome showed that 5 to 10 year survival is very good without any development of regurgitation. But as we all know that these stents may have got tendency to develop stenosis. So some amount of gradients and obstruction was seen. My level of obstruction was seen more than the regurgitation problem. So this is a controversial topic, but some of the selected patients who has got dyspnea on exertion, symptomatic patients, they may benefit from pulmonary valve replacement therapy. With prior discussion with the family that this is not the end of the treatment, they have to be on follow-up, and we have follow-up up to 10 to 15 years. The first percutaneous pulmonary valve replacement was performed by in 2000. So we have only 15 years follow-up actually for that. So all these issues should be discussed with the family, and then decision has to be taken for replacement. But in selected patient, definitely this is advantageous and can reduce the incidences of monomorphic PT. Now this is our next patient who has been, this patient is given by Dr. Nageshwar Rao to me, so I'm thankful to him. So this is a 68-year-old woman who has class 2 dyspnea on exertion and found to have AST on evaluation. There is chest X-ray showing 0.5 and mildly increased vascularity with sinus rhythm PR interval is 140 and incomplete RBBB is there. There is no STT changes and she did not have any coronary artery disease by DSE, that is dobutamine stress echo. So this is nice anterior defect, moderate ostium secundum defect. So we have taken this patient for device closure. This is a T picture. We have taken this patient for device closure, and after device closure, it was found out that the left ventricular EDP has been steeply elevated to 26 millimeters of mercury, which is very high. If we leave like that, they will immediately go on to develop pulmonary edema because acute rise into the left ventricular end diastolic pressure. So what are the issues with the adult ASDs? Adult ASDs, because of the remodeling of the left ventricle that happens due to hypertension or coronary artery diseases, the left ventricle becomes stiff and the diastolic properties of left ventricle changes over the period of time. So once we close this ASD abruptly, the whole of the volume has to be taken up by the left ventricle and the left ventricular pressure, diastolic pressures go on to increase, and that's why they may have immediate diastolic failure of left ventricle. And that's when they may present with pulmonary edema, cough, and venous congestion. Pulmonary venous congestion is possible in all these patients. So before closure of adult ASD, we have to give them probably dobutamine, good diuresis therapy, and always better to check the left ventricular diastolic pressure before closing the atrial septal defect. And after closure of atrial septal defect also, we can put a pigtail into the left ventricle and we can check the diastolic pressure of the left ventricle, or we can check the pulmonary capillary wedge pressure. So is there really need to close all these ASD? They are being living with the ASD for 50 years, 40 years. So what is the need to close this ASDs? Because they are being living with that, let them allow to live few further years. But it was found that whenever we close this adult ASD, they significantly improve in their symptomatic status. In second and third decade of life, they may have development of dyspnea on exertion, palpitation. Some of them may have chest pain related to the dilatation of right atrium and right ventricle and stretching of the pericardium. All these things may make them symptomatic. So this symptomatic status really comes down well, and they have reduction in the heart failure symptoms. But chances of arrhythmias doesn't become normal because there is a dilatation of right atrium and right ventricle which may not normalize, and that's why they have equal incidence of atrial arrhythmias than without closure as well. So all these things needs to be explained to the family. But current recommendation according to the AHA guidelines of in the management of adult congenital heart diseases, ASD closure is indicated in all the adults wherever there is a right atrium and right ventricular enlargement is there, whether they are with symptoms or not, because over the period of time they may develop symptomatic status and they will benefit with the ASD closure from symptomatic point of view. And also class 2 indication is if there is a small ASD without right atrium and right ventricular enlargement, but there is evidence of paradoxical embolism, then they may benefit with the ASD closure. Then class 2, obviously all these things are with mild pulmonary artery pressure and not more than 2/3 of systemic PAH. If pulmonary artery pressures are more than half of the systemic PA pressures, then they have to be closed with a caution because PA pressure may not fall to normal level after ASD closure, and they may not benefit at all with the ASD closure itself. In fact, we may increase their symptomatic deterioration. So all patients with there is absolutely contraindication if there is more than 2/3 systemic PA pressure is there, or if there is a severe pulmonary artery hypertension is noticed. We can perform concomitant MACE procedure if it is associated with atrial flutter and fibrillation, and if patient has been subjected to surgical closure. So these are the indication for ASD closure in adults. So unlike pediatric age group, adult ASD closure is more challenging, not from surgical or transcatheter closure point of view. They are simpler because you can use you can use larger sheets also in them. But physiological changes are more important to be analyzed rather than just the size of the defect. So what all things we need to see in the physiology, because the patient has been subjected to prolonged right ventricular volume overload, and as I was talking that they have diastolic dysfunction of left ventricle due to coronary artery disease or due to hypertension. So we have to see the diastolic properties of right ventricle and left ventricle. Obviously, we should see the systolic function as well. They may have concomitant lung diseases due to smoking. So they may have acquired lung diseases due to the habits of smoking or tobacco. They may have COPD. So all these things need to be taken into account. They may have some of the acquired lung diseases like tuberculosis, bronchiectasis, lung infection leading to bronchiectasis changes, emphysematous changes, so lung diseases. Whether there is a presence of PAPVC, acquired mitral regurgitation due to rheumatic disease or due to mitral valve prolapse, MS or tricuspid regurgitation. All these things we have to take into consideration, and we have to define that ASD closure, how it is going to, how the physiology of ASD closure is going to affect that heart. All these things has to be taken into consideration before subjecting any patient to ASD closure, especially in adult age group. We should see pulmonary veins meticulously. As we are saying here, it is the left lower pulmonary vein, and here it is the right upper pulmonary vein. So what we did in our patient, since I told you that this patient had symptom of dyspnea of exertion, and she was symptomatic with ASD. There was dilatation of right atrium and right ventricle. And as soon as we closed ASD, there was acute rise of left ventricular end diastolic pressure. So what did we do? We have taken off the device and we subjected that patient to dobutamine, given good IV diuresis for almost 1 week. And after that, we have taken a device and we have penetrated that device close to the in the central area. Now, why we have penetrated? First of all, what is the need to close? Because she was symptomatic with ASD, so she will benefit with that left to right shunt. And this penetration, there will be some decompensation to the left atrium. So with all this idea, small fenestration was made with the 11th French of the sheath. We can see the wire is across that, and then it was then there is one catheter into the wedge left pulmonary artery, and it was wedged to check what is the diastolic pressure, and then the device was deployed. This we can see here that there is a fenestration which is working left to right shunt, and this is the T picture that of that ASD closure. So fenestration was working, and this time with preparation with diuresis, dobutamine, her pressures were just 16 to 18 millimeters of mercury after closure. So pulmonary capillary wedge was just borderline elevated. And after closure, she did not go into pulmonary edema. The diuresis was continued, and over the period of time, eventually the left ventricle has remodeled itself, and the diastolic function of the left ventricle has been also improved by non-invasive methods. So this was about that adult ASD, what are the precautions we have to take, and what are the things that we have to see, we have discussed. Now let us just read this hemodynamics. This is very interesting. This patient was referred as an ASD for ASD surgical closure. But on echocardiography, we have found that there is a diastolic dysfunction of right ventricle and left ventricle as well. The atria were dilated, and there is moderate pulmonary artery, PH is there, moderate pulmonary artery hypertension was seen. So with all this idea, we have taken this patient for cardiac catheterization. So let us read this hemodynamics. Anyone want to answer? I've already said that there is an AST, but what else is very prominent finding in this patient? So anybody wants to comment, answer? Yes, there is pulmonary venous desaturation. Very good. Pulmonary sat low. So saturation was low of this patient. The saturation was 85 to 90s, and obviously it was thought while referring that this patient might be Eisenmenger or having severe PH, so right to left shunt is there. But cath is obviously showing that there is a pulmonary venous desaturation is there. So that means what? When do we see pulmonary venous desaturation? What are the conditions? Very good. So lung diseases is one cause. What is the second cause? Pulmonary AVM. Right. So if there is a pulmonary AVM and there are lung diseases, there is going to be pulmonary venous desaturation. But obviously, there is a step up from SVC, IVC to RA. There is a significant step up. That means there is significant left to right shunt. When we calculated, it was 4:1 left to right shunt was there, and pulmonary venous desaturation is there. But there is no step down. That is from pulmonary vein to FA. There is no significant step down is there. That is just 2%, which we may take as a normal, because there is possibility of step down at the left ventricular level itself due to entering of the Tibetan veins, that desaturation may take place. So there is no significant right to left shunt which is happening at this patient. So what else is a problem in the pressure? Anybody wants to comment on the pressure? RA equal to LA. Okay. What else? Okay. High RA LA pressures. Okay. Okay. So what is the cause? So why there is such a high increase in the pressures of diastolic pressure, and capillary wedge is high, the atrial pressures is high. Okay. What else? What else? There is a diastolic dysfunction. What else can lead to the high pressures? So actually, if we see the pressures here, the RA, LA, LV-EDP, RV-EDP, they all are equal to each other. So RV-EDP, LV-EDP, RA pressure, LA pressure, they all are equal. That means there is a restrictive physiology or a constrictive physiology. So equalization of pressures is a characteristic of constrictive physiology. And in a graph, when we have taken, there was typical discordance, there was ventricular discordance which was seen, and this patient has additional constrictive pericarditis, and he had an obstructive sleep apnea, so he was having pulmonary venous desaturation, and CO2s were normal in ABG, and there was an AST. So it is a complex physiology which was happening. There was final impression was there was constrictive pericarditis, there was an AST which is going left to right shunt, and there is an obstructive sleep apnea which is leading to the pulmonary venous desaturation and FA desaturation also. So this patient we have posted for removal of pericardium, that is pericardiectomy. He was posted for, and after pericardiectomy we will cath him again, and then we'll look for what we have to do for the AST. And obviously for obstructive sleep apnea he will require home oxygen therapy or a CPAP therapy. So adult AST, I would say, is the most difficult or a challenging subject. there is high possibility of acquired add-on diseases like coronary artery diseases or hypertension related changes, mitral valve diseases, aortic valve diseases, diastolic dysfunctions, and so on, and pH, obviously pulmonary artery pressure. So this patient had, we can see that there is a post-capillary hypertension. So AST is a benign lesion in this, and there are other additional problems like constrictive pericarditis and lung diseases in this patient. Now let us see one more very interesting case of AST. So this is an AST again. There is a large atrial septal defect. The atria are looking dilated. Now let us see the shunts. We are measuring the AST defect, that is 25 mm. So as we can see here, the shunt is left to right, but there is significant severe tricuspid valve regurgitation is happening, and that tricuspid valve regurgitation flow is in between entering into the left atrium, but the shunt is looking completely left to right. And what is going on here in the ECG monitor? Anybody would like to answer? What is happening in the ECG monitor? So there is just mild pH, TR gradient is just 30, but because of huge annular dilatation of tricuspid valve, there is severe tricuspid regurgitation. Now, anybody would like to answer what is the ECG? ECG on this monitor. So obviously the RR interval is not constant, and even P waves are not clearly visualized here. So this patient was having atrial fibrillation with control ventricular rate because it was less than 100, and severe tricuspid regurgitation due to annular dilatation and mild pH. And just see what is happening to the mitral valve. The mitral valve, there is almost moderate mitral regurgitation due to mitral valve prolapse. So again, a very complex physiology, severe TR, moderate MR, AF with ventricular rate, with control ventricular rate, and large AST which is going left to right shunt. So all this patient, if we straight away go and just close the AST and don't look for the tricuspid regurgitation, mitral regurgitation, obviously after closure of this AST, this patient will land up into the right heart failure, the left heart failure, and post-capillary hypertension because of once we close this ASD, mitral regurgitation will lead to the acute pulmonary edema in the post-operative setting. So we have to consider various physiology. Then on coronary angiography, this patient had coronary artery disease as well. So we have treated her coronary artery disease with the stenting. Then mitral valve was repaired, tricuspid valve was repaired, AST was closed first in cardiac catheterization, balloon occlusion was done, and was seen that what is happening to the diastolic pressures. There was no significant rise in the diastolic pressures. So then we thought of closure of AST with the repair of mitral valve, with repair of tricuspid valve, and treating the coronary artery disease also. So we have to consider their physiology, and we have to really see that what is going to happen after closure of this AST, and then only subject those patients for AST closure. Sometimes this, in restrictive physiology, suppose there is a severely restrictive right ventricular dysfunction or severely restrictive right ventricle, then AST might be helping that patient by shunting right to left, by decompensating right ventricle and right atrium. In all those settings, suppose we go on to close acutely that ASD, these patients land up into right heart failure, persistent pleural effusion, pericardial effusion, and rather than improving their life expectancy, we increase their deterioration, we help in their deterioration. So all ASTs physiology needs to be assessed, adult ASTs especially, before subjecting them for a closure. So this patient successfully managed with repair of tricuspid valve and a mitral valve. Now, let us see this. What is happening to the AST in a long-term survival? So, whenever we close AST, less than 24 years of age, less than 40 millimeters of mercury is the PA pressure, they have got very good survival rate. Okay, up till 25 years, that is another 50 years, they have got very good survival rate. But ASTs, more than 24 years closure at the age of closure is more than 24 years, and PA pressure is more than 40 millimeters of mercury, there is a serious decremental survival we can see there on the follow-up. This is especially due to pH. So this graph is of pH. If there is a pH associated with an AST, and we are closing that AST, so we are actually increasing their symptomatic. We are deteriorating their symptomatic status rather than giving any benefit to them. So severe pH, we should not close, and obviously more than 40 on table should be taken with pinch of salt, thoroughly evaluated. Thorough evaluation is required if we are closing more than 40 millimeters of Hg if PA pressures are there. So this was about the delayed AST closure. Delayed AST closure, as I was talking, they may not be benefited by arrhythmia's point of view, but they may have beneficial role from symptomatic point of view. So all this patient closed more than 24 years of age, but with normal pH, normal pulmonary artery pressures, they have good outcome from symptomatic point of view. And some deterioration at 25 years of age, at 10 to 25 years follow-up is due to atrial arrhythmias. Now this is our next case, that is an 18-year-old boy who is admitted for cardiac cath. He is a cyanotic heart disease, tricuspid atresia with severe PS. His saturation is 75% and hematocrit is 70%. So what should we do with this 70% of hematocrit? Is it acceptable? So whenever we are posting any patient with more than 65% of hematocrit for cardiac catheterization, we have to hydrate them first of all. That is mandatory to, whenever we are keeping them fasting, hydrate them appropriately, check hematocrit again after hydration, and if it is still high, more than 65, then some phlebotomy can be done to avoid contrast-related thrombotic events and renal events. To avoid that, we can do the phlebotomy. Otherwise, what is the indication of phlebotomy? If there is an hemoglobin higher than 20 gram per deciliter or hematocrit more than 65 with symptoms. Now, this is very important. There has to be symptoms with this hematocrit value. Just investigation more than 65 hematocrit, I'm doing phlebotomy, is not justified because routine phlebotomies are not recommended and they will lead to the iron depletion state. It can cause stroke. It can cause reduced oxygen capacity. They are highly dependent on hemoglobin for the tissue perfusion, and we are doing routine phlebotomies that will lead to a disastrous complication like stroke or reduced oxygen carrying capacity or iron depletion state. So whenever they are having symptoms like symptoms of hyperviscosity, like there is an episode of thromboembolism or there is an headache, easy fatigability in absence of dehydration and anemia, then only we should post them for phlebotomy. And again, we should not repeat phlebotomy before 3 months because acute iron depletion can cause, if we are repeating phlebotomies, less than 3 months of time. And headache and easy fatigability are also symptoms of iron deficiency anemia in patients of cyanotic heart diseases. Though their hemoglobin may be spuriously high, but their iron stores may be less and they might be iron depleted. So we have to do their ferritin level or or TIBC levels, that is transferrin binding capacity levels, to show that their iron levels are normal, and then only we should force them to phlebotomy. If they are iron depleted or they are anemic, then better to first give them iron supplementation and monitor their ferritin levels, and once it reaches normal and still they are having symptoms, then only we should force them to for phlebotomy. Now, iron supplementation is also very judiciously we should do this, because as soon as we start giving iron supplementation, their red mass cell index rise very high, and that itself can cause some of the thrombotic episodes. So we have to give them iron supplementation definitely, but it should be monitored judiciously with the ferritins level and transferrin level. And if they are normal, then probably just withhold some days of iron therapy and then monitor them on regular basis. And whenever they required or start developing symptoms of anemia, infertility, then again start giving supplementation of iron. Because iron supplementation sometimes can itself increase into the red cell mass index. Now, pregnancy again is a very vast topic for patients who have got congenital heart diseases, and we are going to see this in our next slide, that how they are very challenging patients. So we have got three groups of patients. First of all, either they are completely repaired with normal four-chambered heart and good ventricular function, normal pulmonary artery pressures, no AV valve regurgitation, no conduit problems. So these are very good substrate, and they have almost normal, they can have almost normal pregnancy. Then there are people who are palliative surgeries like BT shunt, Glenn surgery, Fontan surgery, or conduit repair, because they may have conduit stenosis, conduit regurgitation, ventricular dysfunction related problems. So they are the second substrate, which are not very good substrate to have pregnancy. And then third is totally unrepaired congenital heart diseases. Now, in unrepaired congenital heart diseases, there are some favorable outcome patients like ASTs, small VSDs, small PDAs with normal pulmonary artery pressure, no AV valve regurgitation, and normal ventricular function. So they do very well throughout their pregnancy and may not have adverse events. But unrepaired congenital cyanotic heart diseases like tetralogy of patients, tricuspid atresia, or pulmonary atresia, or AST-TS with right to left shunt, all these patients, they are sick candidates and they carry high risk during pregnancy. So we are going to see all these categories and how to risk stratify them. So this is a risk stratification graph for low risk, moderate risk, and high risk patients. So low risk patients are those who have got small left to right shunt or moderate left to right shunt with normal ventricular function, with normal pulmonary artery pressure. This is very essential criteria, that they have normal pulmonary artery pressures. Then there are patients who have undergone repaired pre and post tricuspid shunt without any ventricular dysfunction, mild to moderate pulmonary stenosis, bicuspid aortic valve without any stenosis or significant regurgitation, with normal aortic root diameters, and some of the mild to moderate valve regurgitations. They are low risk categories and they have favorable outcome during pregnancy. Now there is moderate risk patients, unrepaired palliative congenital heart diseases, uncorrected coarctation of aorta, mild to moderate AS, severe PS, symptomatic arrhythmias, mechanical prosthetic valves. These all are moderate to high risk patients. In high risk patients where probably the pregnancy is contraindicated, NYHA class 3 to 4, they have got adverse events, major adverse events like pulmonary edema, stroke, death, or severe thromboembolism. All these things are major events that can happen, NYHA class 3 and 4. PAH, with or without shunt. Now, PH itself is a contraindication. Severe PAH, Eisenmenger syndrome, probably they are contraindication for the pregnancy. Severe aortic stenosis, Marfan syndrome with aortic root dilatation, they all are very high risk. And unless we treat all these things, they should not be they should not be undergoing pregnancy. All these things should be explained in detail with the family and the couple. Now, there is a Carprig risk index which defines that what is the chances of maternal adverse events. So, these are the criteria which are given, and out of all this, suppose there is a zero risk factor, still there is a 5% chance that with the congenital heart disease they may have maternal adverse event. So risk is not zero, risk is not equivalent to the normal population. If there is a one risk factor, then there is a 25% chance that they may have maternal adverse event. If there is more than one risk factor, then almost 75% chance is there that there is a possibility of maternal adverse event. That means pulmonary edema, stroke, and death. So all these things are possible that can happen. So what are these criteria? What are these risk factors are? NYHA class 3 and 4. Systemic ventricular dysfunction. That is, suppose RV is the systemic ventricle for CTGA and CTG unoperated CTGA. RV ventricular function less than 40% is a major risk factor. Then left-sided obstructive diseases like mitral valve area less than 2 centimeters, aortic valve area less than 1.5 with aortic valve gradient of 30 millimeters of mercury, that is peak systolic gradient. Subpulmonary ventricular dysfunction, moderate to severe MR, TR, or any or AV valve regurgitation like in common AV valve, or mechanical heart valve, because this patient will be subjected to the warfarin therapy, and then heparin related complications. So all these things make them high risk for pregnancy, and probably all these things should be thoroughly discussed with the family. Risk should be thoroughly explained to the family. Then there is a possibility of poor neonatal outcome in some of the diseases. All these risk factors which carry 25%, 50% or high risk for maternal outcome, that itself is an adverse outcome for the neonates as well. Like maternal NYHA class 3 and 4 left-sided obstructive diseases, maternal age less than 20 with congenital heart disease and more than 35. There are multiple gestation, smoking during pregnancy, anticoagulation, and obstetric risk factors. Fontan, desaturation, saturation less than 85%, Fontan surgery, congenital cyanotic heart patients, unoperated, just palliative surgeries are done like Glenn or Fontan or BT shunt. These all may be responsible for poor neonatal outcome as well. Then, before going into the pregnancy with congenital heart diseases, we should understand what are the physiological changes happen during the pregnancy. So, this is the x-axis is the gestational age, and y-axis is the percentage of increase in the cardiac output, stroke volume, heart rate, pulmonary vascular resistance, and so on. So, what happens is the cardiac output gradually increases, steeply increase into the first trimester, then it stabilizes in the second trimester, then again it steeply increases into the third trimester and into the delivery period, that is the peripartum period, and it remains high for almost 48 hours. Similarly, stroke volume also increases. There is an increase in the heart rate, which is gradually increased, but during last trimester there is a significant increase into the sympathetic activity and the heart rate increases. So in later gestation, they are more prone for arrhythmias because of the high sympathetic tone, and heart rate continues to be increased into the peripartum period and initial first week of postpartum period. Then there is a drop in the hemoglobin because increase in the plasma volume. So the hemoglobin mass actually reduces due to increase in the plasma volume. So gradually there is a reduction of the hemoglobin. So those patients like cyanotic heart patients who are hemoglobin dependent into the oxygen carrying capacities, hemoglobin dependent, they have got higher chances of fetal loss due to less, the oxygen delivery to the uterus and the tissue perfusion because of the plasma dilution of the hemoglobin that is taking place. Then there is something which is systemic vascular resistance. This is again very important aspect because it plays important aspect into the Eisenmenger physiology and PH patient. So systemic vascular resistance first increases during the first trimester. It has a dip during the second trimester. Then again it continuously increases during the third trimester and into the peripartum period. So because of the dip into the second trimester itself, an increase in the plasma volume, there is a possibility of right to left shunt, more right to left shunt during the second trimester, and that itself can lead to the increase into the desaturation and increase in the maternal adverse event. Similarly, just not the pregnancy that leads to the adverse maternal event, but peripartum is also a very important phase when maternal adverse events can take place. Like in Eisenmenger's severe PH patient, there is quite possible that maternal adverse events takes place during the peripartum period. May not take place during the pregnancy, but during the time of delivery or postpartum period, they may have adverse event of death. So probably PH patients and Eisenmenger physiology, they are absolute contraindication for pregnancy because we have seen that 50 to 75% of them may have death during the pregnancy or during peri and postpartum period. Now, average risk of mortality with CHD is, we'll just see that. So, in an entirely healthy person, it is 1 in 20,000. Average for population 1 in 10,000. Corrected Pallots is 1 in 1,000. Severe aortic stenosis 1 in 100. So almost very high. Pulmonary hypertension, they are almost 25 to 50% that they may have adverse maternal mortality rate. Now we'll just see the individual lesions quickly. So TOF may have tetralogy of Fallot. Uncorrected congenital cyanotic heart disease may have increase in the desaturation. As I was discussing, due to drop in SVR, they may have more right to left shunt and more desaturation, and they may not tolerate at all the tachycardia that is going to happen into the later trimester and during labor. So they may not be able to tolerate at all that tachycardia. We all know that tetralogy of Fallot patients cannot tolerate tachycardia well. So they may have severe desaturation and maternal adverse event due to tachycardia and drop in SVR, and they may have neonatal adverse events also due to less saturation. If it is less than 85%, it is probably contraindicated to subject them to a pregnancy. Now, coarctation of aorta may have aneurysm rupture, they may have hypertension related complications. Uncorrected coarctation may have reduced uterine flow, and we cannot give beta blockers or antihypertensive therapy because that will further reduce the uterine flow, and they may have drop into the uterine flow, and that will lead subsequently to the fetal loss. So the antihypertensive in presence of coarctation with a gradient is not a good choice. They have chances of both neonatal and maternal adverse event. And then persistent hypertension is also a possibility in coarctation. Then TGA, if patient is with has undergone TGA surgery, ventricular dysfunction is there, then they may have, since mustard or Senning surgery have right ventricle as a systemic ventricle, so ventricular dysfunction is we have to take into account, and we have to closely see the ventricular function, watch for that, and favorably, if ventricular function is normal, then only we should put them for, without any significant tricuspid valve regurgitation, we should subject them to pregnancy. Simultaneously, they are prone for atrial arrhythmias, baffle leak and obstruction, which acts like a pulmonary venous condition may happen if there is a pulmonary venous baffle obstruction is present. Then in CTJ, there is a systemic right ventricle dysfunction, so adverse events are possible with that. So all these things, pre-pregnancy evaluation in all these patients is mandatory. Then in Marfan syndrome, due to aortic root dilatation, there are high chances of aortic root dissection, almost up to 10% chances there. So probably they should not be posted, they should not be going for pregnancy if it is more than 5 centimeter in size. And better to treat first all these abnormalities and then subject them to pregnancy. In Fontan surgery, Fontan patients are on warfarin, so risk of warfarin, risk of arrhythmias, ventricular dysfunction, fetal loss due to desaturation, all these are the problems. But Fontan patient can be individualized. We have to carefully see ventricular function. If a patient is quite they are compliant to the treatment, they will follow proper anticoagulation profile, like they will take properly heparin, and there is no arrhythmia, ventricular function is normal, and there is good saturation more than 90%, then they are probably the favorable patient to have pregnancy. But again, risk of right to left shunt across fenestration, acute ventricular dysfunction, and possibility of arrhythmias and thromboembolism during pregnancy, all these things needs to be discussed thoroughly with the family before subjecting them to the pregnancy, such a physiological change. Now, some of the patients might be on anticoagulation, like valve patients, or Fontan patients might be on anticoagulation. So we all know that the warfarin is can cause fetal warfarin, fetopathy with warfarin is very common. Up to 80% of them may have fetal fetopathy if mother is taking warfarin during first trimester. So warfarin is absolutely contraindicated in first trimester. So to replace that, we have to give low molecular weight heparin, but there are some chances of thrombosis into a mechanical valve, even with low molecular weight heparin. So conventional heparin continuous infusion has to be given in some of these selected patients during first trimester. Then some of the problems with conventional heparin is there is a possibility of bone demineralization, or because of the continuous IV infusion, they may have phlebitis, thrombophlebitis, infection around thrombophlebitis. So these are some of the complications of conventional heparin. So low molecular weight heparin is a preferable drug of choice. So that should be given during first trimester. Then 12 weeks onwards, warfarin can be restarted, and third trimester onwards, again we have to give intravenous heparin and low molecular weight heparin. We should not be given warfarin during delivery because there is a high chances of peripartum bleeding. It's a long-acting drug, and peripartum bleeding can happen. It can cause fetal intracranial hemorrhage because fetus is also at the risk of fetus is also receiving this anticoagulation, and his coagulation profiles are disturbed, and during normal delivery he may develop the fetus may develop fetal intracranial hemorrhage, which is a very disastrous complication. So warfarin has to be stopped 34-35 weeks onwards, and if delivery is being planned prior to that, then 2 weeks prior to the delivery, it should be stopped, INR should be checked, and low molecular weight heparin should be instituted, and then delivery should be conducted. After delivery, warfarin can be safely given because it doesn't cross through breast milk. So anticoagulation of the fetus will not happen, and fetus is not at the risk of anticoagulation related to the warfarin. So after delivery, we can switch safely to the warfarin. Now, most of the time, normal delivery is the mode of choice unless there is an obstetric contraindication. From a cardiac point of view, the major indication for cesarean section is if mother is using warfarin at the time of delivery, if she has not stopped, if she is not compliant, and she has not stopped taking warfarin, or it is an emergency delivery which is taking place, then to prevent fetal intracranial hemorrhage, the LSCS can be done, or if there is a decompensated arrhythmia in the mother, then that is also another indication for LSCS. So in conclusion, it is a very vast topic, and each case has to be individualized. They have the problems related to the occupation, marriage, pregnancy, all these things needs to be discussed thoroughly with the family. And it is not a forgettable disease, like it has been operated tetralogy, so it is just normal. Just leave then that mother. It is not the case like that. We have to keep a follow-up on them. We have to see their QRS duration. We have to assess their symptomatic status. Individual case should be balanced in such a way that they are free from the stigma of congenital heart disease. They can go into the society with head high. They can perform optimal exercise from their cardiac point of view, but simultaneously they are under the scrutiny of medical care. So we have to balance grown-up congenital heart patients very well so that they should not have any psychological burden as well of CST, but simultaneously we are treating them very well. So with modest care, we can give good outcomes to all these patients. It is a multi-centric. We have to sometimes involve the adult cardiologist as well for coronary artery disease, evaluation of mitral valves, and adult surgeons who are well in performing MACE surgeries or mitral valve repairs and CABG surgery. Sometimes we have to involve our adult team and adult medicine people to avoid psychological burden in them. So it is actually a multi-centric, often a team approach. Then risk-benefit ratio and modulation of cardiac physiology over the period of time that happens in the congenital heart, that should be always taken into consideration, and then only decide for any intervention in all these patients. So I thank you all for your presence, your attention. If you have any questions or any queries, so we are open for that.